Hello, everyone. My name is Omid Pourshahid. I'm a pulmonologist and I'm the medical director for pulmonary rehab at Temple University, Philadelphia. It is my absolute honor and privilege to welcome you to this ATS Journal Club. We are celebrating 30-year anniversary of a landmark study in pulmonary rehabilitation. Was published in 1996 by Dr. François Maltais and colleagues. This study was helpful in basically making the foundation of just how we understand COPD as a disease confined in the lungs versus a systemic disease, including many different organs, including skeletal muscles. We are privileged to have Dr. Maltais himself, a world-renowned expert in the field, and also we have two other tremendously renowned experts, Dr. Richard Casaburi and Dr. Martijn Spruit. They collectively contributed to this field a lot. And this session will be started by a brief presentation by Mr. Dan Nguyen, a talented graduate student from McGill. His thesis is focusing on the effects of mitochondrial activating supplement on the skeletal muscles and the clinical outcomes of pulmonary rehab participants. So it's really interesting to see how that study is still helping how we see pulmonary rehab and how things are going to change. My colleagues, Dr. Alan Hamilton and I will be moderators for today. And without further ado, let's begin.
Thank you for the introduction. So I'm Dan. I'm a master's student at McGill University, supervised by Dr. Brian Ross, and it's an absolute honor and privilege to present this landmark work today in this special edition of the ATS Journal Club Assembly on pulmonary rehab. Specifically, we'll be looking at Dr. François Maltais' skeletal muscle adaptation to exercise training and endurance training in patients with chronic obstructive pulmonary disease, originally published in the Blue Journal in 1996. To give some background regarding exercise training and COPD at the time, exercise training was a standard component of pulmonary rehab for patients with COPD because it was known that exercise training improved exercise tolerance and decreased dyspnea in patients with COPD. Now, the mechanisms behind improvements in exercise tolerance and decreases in dyspnea at the time were known to be better motivation for exercise, desensitization to dyspnea, and improved exercise technique and performance. What you're probably noticing, though, is that physiological adaptations to exercise training aren't listed here, even though exercise training-induced physiological adaptations are well understood in healthy people. And this was really because exercise training in patients with COPD were not really believed at the time to lead to physiological adaptations, whether that would be skeletal muscle adaptations or cardiovascular adaptations. And this stemmed from a wider belief that patients with COPD could not achieve the level of exercise training required for physiological training effects to occur. However, some recent work at the time from Dr. Casaburi found that following exercise training in patients with COPD, there was a reduction in lactic acidosis and a reduction in carbon dioxide production and a reduction in ventilation during exercise, all following exercise training. But the mechanisms behind these reductions were not found or not investigated in that study. Now, if lactic acidosis was found to be reduced from exercise training, it was reasonable to posit then that that might be related to an improvement in oxidative capacity of trained muscles, which is what you would normally see in healthy adults. But some prior work had found that exercise training in patients with COPD did not lead to any improvements in muscle oxidative capacity. So there was a pretty glaring discrepancy between these two pieces of work. So it was very unclear why lactic acidosis and other physiological parameters could have improved from exercise training. It could have been possible at the time that maybe the individuals in Dr. Casaburi's work were maybe a bit too healthy or a bit too young compared to the rest of the standard population of patients with COPD referred to pulmonary rehab, or maybe there was another mechanism behind the changes in lactic acidosis that hadn't been identified yet. So what Dr. François Maltais set out to do was investigate the possibility of inducing a physiological training effect in patients with severe COPD who are representative of those that would get referred to pulmonary rehab by specifically looking at skeletal muscle adaptation following endurance training. So to do this, patients with moderate to severe COPD were enrolled in a 12-week exercise training program, which was 3 sessions per week. And each session consisted of 30 minutes of aerobic cycle exercise that was supervised by a physiotherapist, and the intensity of which was targeted at 80% of the maximal oxygen consumption. And I'll get into the next slide of how that was determined. Supplemental oxygen was provided as needed to the patients, depending on the patient. And in addition to aerobic exercise, there were also upper extremity exercises, self-paced walking, and stretching included in the exercise training program. In terms of study assessments, 2 weeks prior to the exercise training, the patients completed baseline lung function testing, which included spirometry, lung volume testing, and diffusive lung capacity testing. They did a vastus lateralis muscle biopsy to look at glycolytic enzymes, which were lactate dehydrogenase or LDH, hexokinase HK, or phosphofructokinase or PFK, as well as oxidative muscle enzymes, citrate synthase CS, and 3-hydroxylacyl CoA dehydrogenase or HEDH. And finally, they completed an incremental cycle exercise test in which they found the peak work rate and maximal oxygen consumption of each patient, and that was using exercise training intensity prescription. They had their arterial lactic acid concentration at each minute of exercise measured, and they also had their breath-by-breath minute ventilation, oxygen uptake, and carbon dioxide production measured. Following 12 weeks of exercise training and within 2 weeks afterwards, patients had repeated spirometry, vastus lateralis muscle biopsy in the same place, and they repeated the incremental cycle exercise test to compare the parameters pre and post exercise training. So to jump right into the results, a total of 11 patients with COPD ended up completing the study. There were 8 males and 3 females. They were an average age of 65 years old, and they had a mean FEV1 of 0.99 liters and mean FEV1% predicted of 36%. They had a mean forced vital capacity of 2.49 liters and a mean total lung capacity percent predicted of 116 and an average DLCO percent predicted of 60. In terms of the exercise training, the average attendance was 81% of all sessions, or about 29 sessions in total during the 12-week exercise training program. And in terms of the actual exercise training intensity achieved during the program, you'll recall that the target exercise training was 80% of maximal baseline exercise capacity. And what was found was that at week 2, the patients had achieved about 15% of their maximal baseline exercise capacity. By week 4, they had achieved 49%, went up to 62% by week 8, and by the end of the training program, got to 69% of their maximal baseline exercise capacity. So where did that exercise training lead? Well, pre-training, there was an average VO2 max of 0.87 liters per minute, and post-training, there was a significant improvement to 0.99 liters per minute. In terms of peak work rate, there was an average peak work rate of 49 watts, which improved significantly to 64 watts. On the graph to your right, you can see the relative improvements in VO2 max and peak work rate, and what you can see is that the relative improvement in peak work rate was almost double that of the relative improvement of VO2 max. In terms of exercise testing parameters, at an equivalent work rate, which in this case was the same work rate as the peak work rate achieved at the pre-training exercise test, there was a significant reduction in ventilation pre to post, and there was a significant reduction in lactic acid at the same work rate. Furthermore, there was a significantly improved delay in the onset of lactic acidosis. And what you can see in the graph to the right is like the same things where you have the relative reduction in ventilation for the equivalent work rate, relative reduction in lactic acid, and the relative improvements in the onset of the lactate threshold. And you can see the lactic acidosis relative improvement and lactate threshold improvements were relatively similar. In terms of some of the mechanistic information that we were interested in knowing from this study, there were no changes in the glycolytic enzymes, LDH, hexokinase, or PFK, but in terms of the muscle oxidative enzymes, there was a significant improvement in the concentration of citrate synthase, or CS, post-training, and a significant improvement in HADH post-training. What you can see in this graph to the right is the concentration of citrate synthase and HADH enzymes, our muscle oxidative enzymes, for each individual participant pre and post. And what you can see is the majority of the patients in the study had improvements in their citrate synthase enzymes and HADH enzymes. So if we know there were improvements in muscle enzyme activity, and we know there were reductions in lactic acid, we want to know were those actually related? And in piecewise linear regression, there is a significant association between the relative change in lactic acidosis and lactic acid and the relative change in citrate synthase. And similarly, there was a significant association between the change in lactic acid and the change in HADH enzymes. So to summarize all of the results, there was an improvement in VO2 max, an improvement in peak work rate, showing an improvement in exercise tolerance. There was a significant reduction in ventilation and significant reduction in lactic acid, as well as a significant improvement of the onset of the lactate threshold. And those were associated with improvements in muscle oxidative enzymes, citrate synthase, and HADH. So these results cumulatively confirmed that it was possible to induce a physiological training effect in patients with COPD. And the reduction in lactic acidosis seen in this study was related to improvement in skeletal muscle oxidative capacity, as measured by the muscle oxidative enzymes. And furthermore, and importantly, the physiological adaptations we saw were in patients with severe airflow obstruction, which was very promising. Something of note was that at baseline, patients in the present study had decreased skeletal muscle oxidative capacity and early exercise-induced acidosis compared to healthy individuals. And this is a key finding that's consistent with skeletal muscle dysfunction or individuals who have skeletal muscle dysfunction. So this was very important in recognizing skeletal muscle dysfunction as a systemic part of COPD. Furthermore, this study showed that exercise training induced reduced lactic acidosis, like you would see in healthy individuals, as well as in the previous findings of Dr. Casaburi's work. But the reduction in lactic acidosis of patients in the present study was actually smaller than what you would get from healthy individuals undergoing exercise training, and was also smaller than the patients who trained at a higher intensity in Dr. Casaburi's work in 1991. So this work had a very big impact and also had some important expected directions at the time. Namely, now it was understood that physiological training effects does play a role in improved exercise tolerance and decreased dyspnea, but it wasn't understood at the time what was the relative importance of the physiological training effects in improving exercise tolerance and improving dyspnea compared to motivation and desensitization. Furthermore, it was not known how clinically important the physiological training effect was. And if it was clinically important, was it actually possible for patients with COPD to maintain that training effect after exercise training? Furthermore, it wasn't really known what was the actual efficacy of different training strategies. So patients, as mentioned in Dr. Casaburi's study, that trained at about 80% of their maximal baseline exercise capacity had greater improvements than the patients in the present study who got up to only 69% of their maximal baseline exercise capacity. And even within this study, patients who trained at a higher intensity compared to low intensity showed greater improvement in exercise capacity. Furthermore, in previous work where there was an absence in changes in muscle oxidative capacity, the patients trained at only about 50% of their baseline maximal exercise capacity. So in conclusion, skeletal muscle adaptation to endurance training can and does occur in patients with severe COPD and is associated with a reduction in lactic acidosis during exercise.
Very well done, then. Thank you so much. So I want to start the conversation, and I'm going to direct this question to Dr. Maltais and our experts. Just looking at that landmark study, and like as we saw, like the skeletal muscle adaptation, the physiological aspect of the COPD, not just as a pulmonary disease, but as a systemic. And now, like 30 years later, we are to the stage that we are looking at it as a in a syndemic lens, like with a lot of behavioral, physiological, social determinants of health. How do you see these findings moving to help us basically reshape pulmonary rehab for the future? Or like, how is it going to basically come into the effect going over these 30 years of knowledge that is accumulated?
Well, I can start a little bit. To my appreciation, in the period after Tom Petty described pulmonary rehabilitation and showed that people, felt a lot better after rehabilitation, it was a sort of reputation of being sort of a touchy-feely kind of intervention, and people don't pay for touchy-feely interventions. So the establishment of a physiologic basis, I think, was very important. And I think Dan did an incredibly nice job summarizing the sort of the course. The Bellman study was very discouraging. But even at that time, there was a letter to the editor saying, wait a minute, you've used very low training intensities. You probably could have done better. And there was a paper in the late 1980s that was influential at Andy Reese's group, showed that people with COPD could exercise at high fractions of their peak exercise tolerance, higher than healthy people. And that sort of led to some of the stuff we did, and then some of the stuff that François did that really showed why Mike Bellman's very much before his time paper was really wrong. And the issue of skeletal muscle dysfunction came to the fore. And you'll remember that it was 1999, a 60-page document, 40-page document was published in the Blue Journal on skeletal muscle dysfunction, establishing it as a very important comorbidity in COPD.
Yes, from my, Dan, thank you very much for your very nice review of our paper. I think that you look very young through that, at least through the skin, but I find that you have your perspective, your historical perspective of the field is exactly the way I see it. At that time, we had our predecessor, they had made important advancements in recognizing that patients would feel better and do more doing pulmonary rehabilitation. We had access to a few good randomized clinical trials about pulmonary rehabilitation, but the physiological foundation of the intervention was not established. And as you rightfully pointed out, the paper from Dr. Casaburi was very, very important. Actually, this is the paper that brought me to the field. I remember very well Richard presenting this work in a rehab meeting in Denver, in Denver in 1992, I think, something like that. So it was a wow paper for me. And so it was like the next logical extension to that work from Rich Casaburi and Italian colleagues to do muscle biopsy and to show that it was possible to induce some sort of physiological adaptation. At the time, the work was very well received. It was convincing, but still some controversy because of the work, the paper published by Mike Bellman. And perhaps I'd like to acknowledge also Dr. Bellman's contribution because he was way ahead of his time. His muscle biopsy study was published in 1981. So it's amazing. But something important to keep in mind, to bear in mind, is that subsequently to our work, other investigators sort of confirm what we found in the sense that, for example, investigator reported improvement in fiber type distribution in the muscle following exercise training, improved or more efficient energy metabolism of the quadriceps with exercise training, reduced muscle fatigue, the possibility to induce some sort of muscle hypertrophy and improving muscle strength. So what we found in our small muscle biopsy study was supported by the findings of other colleagues throughout the world. So I would say that right now in 2025, I don't think that no one would argue that it's not possible to induce or to improve muscle physiology with exercise training. Despite this, I find that pulmonary rehabilitation is not at the level where it should be. It's still difficult to, for example, to support the intervention, to find financial support for the intervention. But nevertheless, I perfectly agree with you that that being able to have some hard physiological data showing the efficacy of the intervention was very important for the acceptability of the intervention. And if I go back in the early 90s, no one was talking, or very little people were talking about the role of pulmonary rehabilitation in COPD guidelines. I did not learn that much when I was doing my clinical training. But nowadays, if you look at all the clinical COPD guidelines, pulmonary rehabilitation is there. So clinically, we still have a lot of work to do to give access to the intervention, but nevertheless, people now acknowledge the importance of the intervention.
I will also add some comments here. Thank you, Dan, for the summary. François, congrats on this paper. It was in 1996. I just started studying physiotherapy. I was 21.
Thank you, thank you.
I probably didn't even know what COPD meant at that time. So, but so it's very nice to have this discussion now. Yeah, it's a landmark study, even though it's a small sample. It's well designed, and it emphasizes the importance of the exercise physiology, and that you have to go to a specific training intensity. What I thought was very interesting is that you start to aim at 80% of the intensity, the peak load, but you end up at very low numbers, to be honest. So I had a question on that, like, was that purposely done, like very low, like I think 14-15% of the peak load in the first 2 weeks? That seems rather low. But I think the paper does show that you can obtain muscle adaptations by exercise training. That's very important to establish. I'm also surprised that since 1996, the number of papers that focus on this topic is very limited still. That's really unfortunate. I do understand it's very burdensome to take muscle biopsies and then undergo the training and repeat the muscle biopsy. But it does give you the final proof of the intervention, of course. Perhaps also for the discussion, and we already were discussing it also offline before the broadcast started. What happens when we go do exercise training without supervision? What happens then at the level of the muscle? If you do virtual reality or home-based programs, or that's of course a matter of debate. I think just using a walk test may not be sufficient to establish really the changes that are at the level of the muscle. So perhaps you can comment on that, François.
Yeah, thank you for your comment. And before I forget, despite the fact that this journal club today is a remembrance of my age, I feel touched and honored by the selection of our paper. So thank you so much for the kind words about our work and your appreciation of its importance in the field of pulmonary rehabilitation. As one of my colleagues told me, at least I had at least one good contribution to the field, so I'm happy about that. The paper was published.
You're too modest. There are more than one, François.
The paper was published in 1996. Our rehab program took form in 1992. So we had a little bit of experience with exercise training. And by the way, Martin, it was the physiotherapists who were doing the exercise training in our program. And and we wanted to crank the exercise intensity like Dr. Casaburi did in his work. But the physio team didn't feel it was actually possible to achieve that goal in an 8-week program. So that's why we decided to prolong the duration of the training program to 12 weeks, starting low, not to discourage the patient, to make sure that they get accustomed to exercising and trying to increase the exercise intensity. As you pointed out, we were unable to reach 80% in all subjects. On average, it was 69%. So still, I find that it's a relatively high intensive training for them, and perhaps due to the prolongation of the training intervention, also like the training volume was somehow we were able to compensate a little bit the lower training intensity by prolonging the duration of the exercise training. So yes. But still today, I by personal experience, looking at the patient, looking at the rehab program, we have them with us. We want to push them to their limit, not to the point that they will want to stop coming to the program, but we want to have the best and the most intensive intervention that we can while we have the patient with us. I also like your comment, Martin, about the fact, do we know with home intervention or community intervention that we can achieve that goal? We don't know that. There is this general sense of appreciation from RCTs that it's home rehab or community-based rehab is equivalent to outpatient directly supervised rehab. But actually, I agree with you. I'm not sure we know that to that point. Perhaps we can improve quality of life. Perhaps we can improve 6-minute walking distance to similar extent with both types of interventions. But if we had to repeat this sort of physiological study, I'm not sure that we would be able to show that kind of results. So the clinical implication of this for our program is that when it's possible, we prefer to have the patient with us and directly supervise the patient, at least for a certain period of time, like 8-12 weeks, for example. When it's not possible, of course, I think that there is a place for remote rehabilitation to reach a larger group of patients, but when it's possible, we prefer to have them with us.
Well, let me expand on that a little bit. Now, let me talk about the situation in the United States, which is really very, very poor and very worrisome. I think that in Europe and Australia, things are better because better studies have been done. But there's a proliferation of commercial programs that really they're calling themselves pulmonary rehabilitation, but the outcomes have not been studied. That even exercise outcomes are not included in their sort of evaluation of their program. We really need to do a better job. I'd love to see some physiologic studies that would evaluate these sort of programs. It just is a really a crucial moment, frankly.
Yeah, actually, if I could just bring some of the audience in, Mike Bellman, actually, who has been referred to a couple of times. So it's great that he could join us today. And Mike has his hand up. So Mike, you have a question or comment?
I need to unmute.
Oh, you're
No, we can hear you. We can hear you.
And then, you can even show my face if possible. I don't know if that's, but it doesn't really matter. Well, first of all, delighted to join the discussion, and I think I'd just like to make one correction. The landmark study was mine. The other study was the study that disproved how I misspent my youth and came up with the wrong conclusion. So that was one of the areas that, in addition to inspiratory muscle training, which was a secondary goal that I subsequently devoted a decade to, also proved to be a big bust. But what I wanted to do is pick up on a couple of points that have been raised now that I am in my 9th decade, early on. But the issue of the applicability of this to older age groups, because I find that much of what the literature has is research done in people in their 50s, 60s, and 70s. Whereas certainly in the United States, the majority of COPD patients are above 70, and probably if a study were to be done in Medicare in the United States, which only starts at 65, I'm sure the ages would be higher, and it would be interesting, again, as Rich points out, that it might be worthwhile looking at the old in terms of the response, because that's where the majority of COPD is and where the majority of morbidity and impaired lifestyle is. So those were just a couple of the points that I wanted to make. Thanks.
Dr. Bellman, may I ask you a question? Now you're in the call. If you would redesign your study from 81, what would you do different?
Well, I think part of it, and I don't know how Dr. Maltais did the biopsies, but we used a very small needle, mainly because the first practices were done on me. And so I think that maybe the specimens we had were not optimal. That would be one thing that I think, and I'm be interested to hear what the size of the biopsy piece was, because that may not have been enough to get to the appropriate results.
In terms of, we use the Bergstrom needle, from Sweden. It's a 5-millimeter needle, and typically we were able to obtain, I'd say, if I recall correctly, like 120 milligram of muscle, something like that, in that range. Sometimes a little bit more, sometimes a little bit less.
Yeah, no, clearly we used a true cut needle, and I think our biopsy specimens were much smaller.
Okay.
Mike, I agree that your study was absolutely way before its time and really crucial.
Yeah.
And I remember debating with you about inspiratory muscle training versus leg muscle training in the late 80s, where you had data and I had none. So it was a good time.
Francois, in your paper, you used the peak VO2 and the CPAT to evaluate the efficacy of the exercise program. Well, now we probably would use a constant work rate test. Would you agree to that?
Yeah.
And
Yeah.
what about other outcomes in the muscle, molecular outcomes? Do you also focus on that now?
We don't do, right now I'm not involved we're not involved in muscle biopsy, apart with some work that I'm doing with André Niber from Sweden. And André is finalizing a very nice paper on the use of non-linear exercise training, resistive exercise training in patients with COPD. A little bit what the paper was published like 10 years ago using non-linear aerobic training. I find this very nice, and there is a nice physiology. And I know that with André, we did muscle biopsy before and after, and we looked at enzyme activities, but we also looked at some markers of mitochondrial growth within the muscle, some molecular marker that, I'm not an expert in the field, but we could do something more, perhaps more specific, more sensitive than only looking at enzymes, looking at other markers of mitochondrial function. Molecular marker of mitochondrial function. I haven't seen the muscle biopsy data yet, but I saw the exercise physiology data yet already, and it's very interesting, very promising as well. Although there is this complexity of supervising a very sophisticated exercise training program. Coming back to your question about the constant work rate exercise, yes, I think that overall whereas we typically find 10-20% improvement in peak VO2 with exercise rehab. It's not unusual that we double exercise capacity during constant work rate, some maximal exercise in COPD. So we would probably use that test also.
Yeah. And in your muscle outcomes, you used enzymes which are related to the oxidative metabolism, but also to the glycolytic metabolism.
Yeah.
Was there a hypothesis in advance that you would consider that could all improve, or?
Yeah, typically with the sort of exercise training that we used on a bicycle, you don't see much change in glycolytic enzyme activity. So the results that we find were more or less, predictable, I find, and consistent with previous work done on other population, healthy controls or patients with heart failure, for example. Yeah, that's perhaps another sort of confirmation. The work, if you look at the work that has been done with notably Martin Sullivan, a cardiologist from Duke, they did more or less the same thing in patients with chronic heart failure and found similar results. Low muscle oxidative capacity and improvement with exercise training.
Francois, I don't think I've ever discussed this with you, but I can't tell you how many times I've shown that slide with the hydroxyacetylcoa and citric synthase improving, but those improvements are not all that impressive. I mean, healthy people doing an exercise training program, a vigorous one, will double their concentrations. The question is, can we do better?
Yeah, I think so. I think so. Perhaps with better design exercise intervention. Some years ago, I was asking myself about whether or not the training response is normal in COPD, but I was never able to find a good experimental design to answer this question, because you would need to compare two groups. We would need to compare patients with COPD and healthy controls, and say that you train the COPD as hard as they can, and you train the healthy control as hard as they can, and you find, for example, that the training response is smaller in COPD, then you would tell me, well, François, it's kind of obvious, your patients, they train at lower exercise intensity compared to the healthy population. Okay, so say I designed the study differently and I decide to exercise the controls exactly at the same level, exercise intensity as we use in COPD, and find, for example, similar results, you would argue then, well, it's obvious, François, your healthy control, they didn't train. It was the intensity was too low. So I was never able to find a good way to answer these questions, but but my general feeling is that because we are unable to push them as hard as we could push healthy controls, the training response is on average perhaps smaller than you would see in healthy controls. But you could argue also that there are some molecular mechanism within the muscle. The muscle is diseased and it responds, it improves with exercise training, but it's not like a quote unquote normal response. But it's a difficult question to answer. And on top of that, you add the heterogeneity of the training response that is seen also in healthy controls. You can take two brothers. This has been done in Quebec City by the group at the university, kinesiology group at the university. Two twin brothers. They're not identical, non-identical twin. They do exactly the same training program and they respond differently. So on top of all the complexity, you have a heterogeneity in the training response from one person to another. So that's a difficult field to investigate, I find.
But there are also experiments if they have non-responders in healthy subjects. If they have non-responders and they extend the duration of the exercise program, you see the increase in the number of responders. So it suggests that volume duration somehow is part of the heterogeneity or the answer to the heterogeneity.
Mm-hmm.
But also folded into this is the controversy about how much deconditioning plays in the muscle dysfunction versus something inherent to COPD. That again makes it more difficult to strain out.
And we do have a couple of hands up in the audience, so I'd like to offer them a chance to speak. I think Harry Rossiter was the first who had his hand up. Harry, do you have a comment? That's great.
I was just going to follow up on Francois's comment. There was a paper from a Scandinavian group, Brunstad was the first author, where they did single leg knee extensor training and were able to, and they measured VO2 across the limb, as well as taking biopsies. And they were able to get COPD patients from about 60% of the control group up to 100% of the control group with their training program. So if you really aggressively train the muscle, take it out of the constraints of the pulmonary impairment, those patients at least were able to, I think, get what I would consider a normal response. There was no evidence of impaired training response.
Very interesting.
Yeah, and Bill Stringer has a comment as well.
I just wondered, with MotorPack coming out and whether there's molecular markers we could be using as muscle biopsies or a lot in terms of patient and also analysis. Are there other molecular markers that may be on the horizon that we can use both in patients or normals to really understand the training response?
I'm not the good person to ask these questions, but I believe that there are biological markers of mitochondrial function, mitochondrial growth. And although I wouldn't be able to name them today in this presentation, and I know that there are some markers that can be used beside, the enzymatic activities. Perhaps other colleagues, Harry or other colleagues, could comment on that.
And just maybe open up as well to anybody else in the audience who has questions. By all means, raise your hand, and we'll bring you into the discussion.
Perhaps then another question to François, because now it was mostly focusing on whole body exercise training in 1996. Is there also a role for resistance training or other interventions at this moment?
Yes. I had to read again my paper to make sure what we did in terms of exercise training. But in that paper, we used exclusively aerobic exercise training program. But I guess, as most of you, our training program also involves muscle resistive active exercises, and I find that they are very, very important in terms of addressing the issue of muscle weakness, and something that perhaps we don't pay enough attention to as an outcome is muscle endurance. For example, the endurance of the quadriceps, which can be markedly improved by, specific targeted muscle exercise, low intensity muscle exercise, but high repetition. So, and also I find that in general, the patients, they like the muscle exercises because they feel less short of breath while doing them. So muscle strengthening, muscle resistive exercises, I find is a very important part of the exercise training program. And perhaps I should mention Harry was talking, and Richard was mentioning the first ATS statement on limb muscle or skeletal muscle in COPD. The second iteration was I led the second iteration. It was published in 2014, and the third one is underway right now as we are speaking, under the leadership of Harry and André Nieberg. So it will something perhaps to be followed in 2026, something like that. I know that they had a meeting at the ERS meeting. So it's nice to see that this field is still continuing. At one point, it was very exciting. We had some specific limb muscle exercise session, limb muscle session at the ATS and ERS meeting. So at one point, it was quite big. It was a very nice and interesting field to follow. But more to hear with the revised version of the statement.
And about your heterogeneity in the response to exercise training. And although your sample size was only 11 patients, in the citrate synthase in figure 1, you see that 3 patients go down.
Yeah.
Very steep.
Yeah.
Do we have any explanation for that, or is it just a biological variation in response to exercise, or are those the non-responders or non-adherent ones, or?
My first thought was that it's perhaps related to the variability of the measurement, related to the quality of the sample, for example. It's interesting to know that in Mike Bellman's paper, there was also some patients with decreased citrate synthase. So, Martin, I wouldn't know if it's a true signal or if it's just a noise of the measurement, and I would tend to think it's perhaps the noise of the measurement.
Yeah, it would be good to repeat these studies with larger sample sizes.
Larger sample size, yes.
Yeah. And was there any association between the change in the oxidative enzymes and your VO2 change?
You mean a relationship between the two? I don't know the answer to this question.
I remember with lactate, it was also shown like that, but I don't think it was. Yeah.
Yeah, but I don't know the answer to this questions. No.
If there is no questions from the audience, I wanted to repeat and basically have another question to the panel, talking about repeating or potentially repeating some of these studies and proving some of these physiological differences that was made with the exercise, with the adaptation, and potentially, like it was discussed earlier, putting virtual or these hybrid models coming to basically prove themselves to be as good or equal, not to just as a matter of 6 minutes, but just like other physiological markers. What would be your choice of index or specific objective to measure for a patient with in-persons versus virtual that you would choose to see as a practical aspect? Because as you mentioned, the biopsy consenting patient, there are not going to that many, and over this many decades, these type of studies, they are not being repeated frequently. So what would you choose to, if you are going to choose something for a study at this point?
If I can start, I don't think I would repeat our study simply like it was an observational study. I appreciate the fact that it's only 11 subjects. but this principle that we can improve physiology with exercise training has been repeated, reported also by other investigators using other methodologies. So I don't find that a very important question to answer. To me, it would be more like, can we achieve this similar results with different sort of exercise? Can we improve the exercise training, the design of the exercise training program? Can we do as good if we do it remotely compared to patients that are directly supervised, for example? That would be more would be more tempted or interested by these sort of questions. I think just doing an exercise, all exercise testing, like either maximum exercise test or submaximal exercise test, looking at physiology, heart rate, ventilation, very simple thing, like the threshold, for example, could be very, very informative, looking at symptoms as well during these tests. If you want to do more in terms of looking at muscle function, yeah, I understand the limitation of muscle biopsy, but we could perhaps do muscle, measuring muscle strength or muscle endurance, for example, non-invasively, trying to quantify muscle mass. In one of our studies, the previous studies, we looked at the CT scan, for example. That's again, but hooking things of bioelectrical impedance, for example. So I would look at the whole body exercise response, trying to find markers of improved physiology, and also some sort of non-invasive muscle markers, like I said, and trying to compare different exercise training modalities.
Yeah, and to try to answer your question directly, I'd put a plug in for constant work rate exercise testing. Again, rehabilitation benefits are really protean, but there's a lot of focus on exercise capacity or exercise tolerance and ability to do things in your everyday life. And Alan Hamilton and I published a series of studies that tried to link constant work rate exercise testing to ability to do things in your everyday life. The studies that Francois and I did in the 90s were sort of morphed into Dennis O'Donnell's stuff with dynamic hyperinflation as the sort of mediator of what the patients had to stop exercise when they achieved dynamic hyperinflation. And we can measure that with constant work rate exercise testing, and it's a very cause and effect sort of thing. So that if you're asking me for one measure that should be included in these studies, that would be the one. Not only the duration of the exercise test, but the physiological accompaniments.
If you ask me, Omid, then I would not choose one test. I think a multidimensional outcome would justify the comprehensive intervention. Because if we see, years ago, we compared in more than 2,000 patients the efficacy on a walk test and a constant work rate test in the same patients, and there's some overlap in responders, but not completely. So depending on the test you choose, you have your responders or non-responders, and the same is true for symptoms, quality of life, ADL, and so on. So if you would ask me, how would you evaluate the efficacy of a rehab program, I would do multi-dimensional. When it's about what program for which patients, I think we go too much into the fact that a one-size-fits-all approach, more or less. I think the degree of severity or complexity based on different outcomes, physical, emotional, social functioning, should be the guide to determine which type of rehab is suitable. I think there are very severe, complex patients who do not qualify for home-based type of approach. And the other way around also. There are patients who have some limitations, but are not so complex that they need to go to a center-based or even inpatient rehab program.
Thank you so very much. Dr. Bellman, I see your hands up, please. Have a comment or...
Yeah, and I think after that, I think Marilyn Moy might also have a question. I think her hand was raised, but maybe Mike can go first and then we can go on to Marilyn.
Yeah, thank you. I just wanted to raise a different area quickly before the meeting ends because of the distinguished panel that we have today. In the latter half of my career, I left strict pulmonology behind and actually worked for a health insurance company. And as such was exposed to a large number of or a great deal of information regarding morbidities in the elderly. And COPD is certainly way up on the list. What is striking in the results in the United States in the past couple of years is the reduction in the cost of care in the organized value-based care programs within the Medicare population. And yet the uptake of COPD rehab is in the very low single digits. So the question that really I see is whether or not or how programs should be devised or structured in the future, whether it's inpatient, outpatient, but what the program should consist of, because it seems that tremendous gains are obtained in a number of chronic diseases, including COPD, yet the use of rehab is minimal. So I'm just wondering to what extent these physiologic changes really carry over to meaningful impacts on daily life.
I think that we have. I perfectly agree with your evaluation. It's the same situation here in Canada, that the uptake of pulmonary rehabilitation for many, many reasons is low. In my hospital, we're lucky to be supported by the administration of the hospital, but it's not supported by the healthcare system itself. The public healthcare system, we have to find innovative ways to support the intervention. I find that we have many clinical evidence that what we see in the lab, what we see in the rehab center, translate into daily life of our patient. Although this translation is difficult to measure, but we see, for example, reduced hospital utilization, reduced consultation to do emergency room. We see more autonomy in daily life. When we ask about quality of life, we see improvement as well. I was very interested by administrative data set from US showing that after an hospitalization, those who were referred to and could initiate pulmonary rehabilitation before 90 days compared to those who had access later or did not even have access to rehab. The mortality rehospitalization was reduced as well. Although in that study only, and this is to your point, Dr. Bellman, only I think 1% of the entire study population had access to pulmonary rehabilitation. But nevertheless, I find that we have plenty of evidence that it's effective to improve many outcomes. Still very difficult to have reimbursement for this intervention. And it's the same thing in any field of rehabilitation. When we had the shutdown related to COVID, the first intervention that were shut down was the rehabilitation intervention in pulmonology, in cardiology, in neurology, in orthopedy, for example, all the field. So I don't know if it has to do with the fact that we lack data. I don't think it has to do with the fact that we lack of good data. It has to do with the fact that the medical community generally consider pulmonary rehabilitation as a second tier, intervention, less important than other more acute care intervention that we use. And we need to change that philosophy. But obviously, this has been very difficult to achieve, despite all the evidence that we have to support the intervention.
Well, that's interesting, Francois, because you were referring to the Lindenauer paper in the JAMA of a few years ago. If a drug would have that result on survival, everybody would implement it.
Yeah.
We show this with epidemiological data, not a randomized controlled trial, but with epidemiological data, and still does not transfer in different processes in healthcare. For reimbursement problems and so on. I think Marilyn is in the call somewhere.
Yeah, I think Marilyn, I think you had your hand up. Did you, Marilyn?
I did. Can you hear me?
Yes, we can, Marilyn.
Yeah. So I had a question, but I wanted to respond to Dr. Maltais' comment that I think that there's also an issue here around behavioral interventions, that providers, in terms of referring their patients to us, really think that a 12-week program isn't really going to create sustained behavior change. And so they're quite skeptical that, sending their patients to us here in Pulm Rehab is really going to have meaningful, lasting changes. That's one comment. But my question was really to ask the panel about your thoughts about what the relationship you think exists between what's changing in the skeletal muscles and these outcomes of decreasing risk for COPD exacerbations and this decreased risk for dying. What are your thoughts about what those mediators are and why that, what's happening in the skeletal muscles? Can that explain what these observations?
That's a great question. That's a great $1 million question. I'm not sure I have a good answer. Well, in 2002, there was a paper published in the New England showing that mortality is reduced in people who have good exercise capacity. It was published by Dr. Myers, first author. So people with good exercise capacity measure on a treadmill, their mortality is reduced compared to those who are less fit. And this is irrespective of the risk factor for mortality. So they looked at COPD, dyslipidemia, diabetes, hypertension, obesity, throughout the board. Those who are more fit, they survive longer. And this observation is true even in healthy controls. Now, if you look at the chain, the physiological change of VO2, I mean, you have the lungs, you have the heart, you have the muscle. This is the Wasserman very classical figure. So I think that, if you improve one aspect of the chain, the muscle, you probably improve somehow the heart function as well. You improve peak VO2. I mean, this all goes together. And the very convincing data that these improvements relate to survival in all sort of conditions.
There's a counterpoint that was published, I think it's either being published or published recently, debating whether it's the fact that people are more active after rehabilitation or that their muscles or their sort of fitness issue. And at least I come down the side of it being fitness, as Francois says. I think Harry Rossiter has some data to this effect. That doesn't tell you exactly what the cause and effect is, but I suspect it has to do with the general fitness.
Very well said. Marilyn, you still have another question? Your hands are still up. Oh.
No, I'm all set. Thank you so much.
Okay, very well. This is 12:59. I was wondering if there is no other questions or comments. I wanted to thank all the expert panels and all the participants for joining, and I truly enjoyed it. I wish everybody have a wonderful day. Thank you so much.